Welcome back to another episode of Advocate, Holding Healthcare Accountable. I want to welcome back Chad Erickson and Barry Howell for a conversation about what is ailing physicians these days. What we know is that physician burnout, physician stress, physician dissatisfaction is at an all-time high. We also know that small private physician groups are being squeezed out and bought out by hedge funds, private equity, large hospital corporations. And we want to have a conversation about the effect that that has on physicians as well as its potential impact on patient safety. Advocate, holding healthcare accountable. This podcast is my way of sharing what I've learned about the mistakes, the cover-ups, and the ways we can all protect ourselves. We're all in this together. Well, Barry and Chad, welcome back again. And I think it's so important that we reach across the aisle, so to speak. So many physicians, hospital executives, nurses, whatever, they think that plaintiffs' lawyers like me who do medical malpractice cases are the enemies, and that we're just looking for a gotcha, just looking for a way to sue somebody, which is definitely not the case. You know, we turn away 99% of patients that come to us, even if they have been harmed by a preventable medical error. And that's not just us, that's most medical malpractice lawyers, because of the legal environment that's been created over the years by politicians. And so, you know, one of the things that I'm trying to do with this podcast is there's accountability, which is when something bad happens, what do we need to do to hold the wrongdoers accountable? And in holding them accountable, how does that help make things safer for the next person? But there's a whole other side there that comes before that, which is prevention. And it's going to take people from the outside and people from the inside to fix the problems. And so while we have very different perspectives, you guys are insiders, I'm on the outside, we would typically be enemies. One thing we all have in common is we're all patients. Our children are patients, our parents, everybody we love is a patient. So I commend you guys for the work that you all do every day trying to make healthcare safer for patients. So today we're going to talk about kind of what's happening with the system that is impacting physician satisfaction and the correlation between, if the physicians are unhappy, is there a correlation there with good physicians becoming unsafe physicians because the system has just burned them out and crushed them? So just for a review a little bit, Barry, tell us a little bit about your background.
Sure. I've been in healthcare for almost 20 years now, as everything from a physician recruiter to I've worked for major healthcare systems and hospitals. I've opened brand new hospitals from the ground up, and I've worked for neurosurgery practices and orthopedic practices for the last 12 years.
Great. And what about you, Chad?
I've been doing this for about 22 years. I started in dentistry, though, with a large dental group, and then got into recruiting as well. I've been on the board of some pain management companies, imaging companies, physical therapy companies. I've also helped lead a neurosurgery group, and now I'm currently with an internal medicine group.
And you guys are both uniquely qualified and positioned to talk about these issues because you both currently run physician groups.
That's correct. I'm currently the CEO for Plano Orthopedics. It's a group that's been around for almost 50 years in Plano, Texas, and amazing group of physicians.
Really is a good group.
Well, it probably has good leadership, but that's just me.
It does.
So one thing that we hear is that physician dissatisfaction is at an all-time high. Is that true?
It is true. A statistic I point to pretty often from the AMA is almost 80% of physicians are now employed. And so that's a staggering statistic to me that, it begs the question, why? Why are the majority of physicians employed in America? And I think it points to the challenge of remaining independent. It's a byproduct of consolidation, of economic pressures. I like to say the physician is surrounded. Just this year, an orthopedic example is many orthopedic surgeons will see a 9% reduction in reimbursement rates from Medicare. And to the average person, they say, well, why is that a big deal? Well, it's a big deal in the sense that the profit margins for a lot of practices are 2 to 10%. And so any reduction in reimbursement will have a bottom line impact. And for orthopedics, at least, a lot of our patients are Medicare population. So you say, well, it's just a 9% in Medicare, not commercial payers. Well, that's true, but sometimes almost half your practice is Medicare. So that 9%, it gets further amplified. And that's just one example. Most commercial payers tend to follow what Medicare does when it comes to reimbursement. That being said, costs have gone up, in particular staffing costs. After COVID, staffing costs went through the roof. It was hard to get people to want to come back to work. Everyone, and rightfully so, right? We were all worried and scared. And so the world changed. But those costs didn't go back down once we sort of calmed down from COVID. So staffing costs have gone up. I probably don't have to talk to you about inflation. So the cost of anything has gone up as far as supply costs, insurance costs, property taxes, on and on and on. All those things that an independent practice, regardless of specialty, are facing. So when you're doing the same amount of work and you feel like you're about as busy as you can be, and you're seeing as many people as you can see, and your costs are increasing, but your income is decreasing, it really puts that pressure on you as a practice to stay independent without some help. You need some financial help. And so healthcare systems, private equity, hedge funds, as you mentioned, a lot of them offer to come in and have an infusion of capital. They typically buy control of the organization, which de facto makes you the minority. And that means you don't have final say anymore in your practice. So that's the dynamic shift that we've seen happen more and more and more in the last 10 years. And I think COVID really made that accelerate at hyper speed.
So I want to kind of summarize in my way of thinking what you're saying, which is that, and correct me if I'm wrong,
Sure.
if you have a business and the reimbursement rate, the cost that you get paid, the amount that you get paid for the service decreases, the cost of providing those services increases, then the only thing you can really do is put the hamster on the wheel harder, 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 see more and more and more and more patients. And physicians already feel like they're just drowning. They're having to see so many patients. And it's kind of like catching a falling knife, so to speak, with the cuts in reimbursements. And then you have someone like a private equity firm come in or whomever, and their solution is, well, look, we're the experts at cutting costs and turning a more profit by keeping the hamster running on the wheel, the hamster being the physician, and then slashing the cost, fewer staff, fewer resources. And I don't think anybody listening would argue that's not good for patients. It's not good for doctors and it's not good for patients.
It hurts the experience for all those parties. I agree. And I would say there is one thing you can do to mitigate rising cost, declining income, and that is to generate new streams of income. So that is one thing you can do that sort of flies in the face of, that one equation of cost increasing and revenue decreasing, and that is to generate revenue from other sources, and that's ancillary income.
So an example of that comes to my mind would be if you go to the dermatologist, they're likely to have an esthetician where you can get skin care and buy skincare products and things like that.
That's exactly, it's a great example.
Yeah. So when you say 80% of doctors these days are employed, who is employing them?
So that's a good question. The answer is it's a combination. It's a mixture of private equity, hedge funds, healthcare systems, but in some instances, health insurance companies themselves employ physicians, which I think some people don't realize even now.
So the way an insurance company turns a profit is collecting premiums and reducing the amount of claims that is paid out so that there's a delta there. And so in the medical world, if you have a physician that's employed by a health insurance company, they'll collect the same amount of premiums, but the way to increase profit or make a profit is to decrease the amount of services paid out.
There's actually a little bit of a nuance there.
Okay.
And that because of the Affordable Care Act, there's a statute in there where they're only allowed to have a 20% profit margin. So you left out the little piece where I need to make healthcare a little more expensive, so my 20% is higher. Now, I'm not saying that that's happened. Sometimes that just happens naturally
I see.
because of, we have new drugs, we have new procedures, whatever. But insurance companies, their margin is actually set. But you're absolutely right. They want to keep it at exactly that 20%, as close as they possibly can, because that's how they make profit. If they only make 18, they could never get that 2% back.
I see. It's a great point, Chad, to bring that up. But, I'm sure an argument could be made that there are some benefits to consolidation. I don't know off the top of my head what they are. But what concerns me is physician autonomy. I don't want a hedge fund making decisions or a health insurance company making decisions or creating policies that influence my physician's medical decision making. And so what y'all's take on that?
I think you could argue that, there might be some misalignment of interest just because of the nature of the organization. Private equity has to see a return on their investment, right? That's the whole proposition of private equity is large income makers in America. We're creating this fund for, we're going to call it private equity, and then we're going to use this fund to invest in different businesses that we think we can buy at this level. And then by the time we're done in 3 to 5 years, we can sell it at this level, and our investors get to keep the margin in the return, and their investment goes up. Pretty simple concept. But I think there's some unintended consequences, right? When your sole focus, and I don't want to paint with a broad brush. I'm not saying every fund acts this way, but
Right.
when and if the sole focus becomes, well, we've got to hit our revenue goals. How can we cut things to either cut costs, or what can we do to introduce new income streams to hit the revenue goal? That can fly in the face of the physician experience, the staff's experience, and of course the patient experience. By making it a far less pleasant experience at best, and at worst, compromising quality outcomes. And that's the worst case scenario,
Right.
where we're impacting care negatively because our priorities are not in shape.
Exactly. And, it intrigues me and troubles me in the sense that why is healthcare such an attractive target for private equity to invest in?
I can say one answer to that is technology. Ironically, it's one of the last sectors in our country that has fully embraced technology, modern technology. For example, a lot of referrals in many physician practices, regardless of the ownership structure, still receive the most of their referrals via fax. And that's just the truth. The fax machine is still alive in healthcare, although it
Yes.
accounts for 20% of our GDP as a country. That's ridiculous. So private
Yeah.
equity, I would submit to you, would say, well, we can address that with capital to increase technology, to make things more efficient, reduce costs, that sort of thing.
Interesting. Yeah, I was filling out an application for something yesterday and it asked me in 3 different places what my fax number was. And I was like, what, seriously? Because I could probably give you a fax number, but if you fax me, I'm never going to get your fax. Like, the 80s call, they want their fax machine back.
And healthcare is holding on to the bitter end to the fax machine for whatever reason.
Absolutely.
I could tell you 2 doctors right now who have one retired when her large practice group said we're going to electronic medical records, and she's like, I'm out. And then a friend of mine is holding out because he has a small solo practice. And I guess is it Medicare that somebody is mandating that he not have paper charts anymore. He's got to go
It's
electronic.
Medicare.
Medicare.
You can't file claims anymore unless you file them digitally.
And so he's saying, like, I'm out. And so it's kind of crazy. So you said something interesting. You said the independent physician is surrounded. What did you mean by that?
Yeah, so between the economic pressures, between societal pressures, between COVID, I would submit to you not all physicians fully recover from COVID, maybe mentally and some emotionally and some both. And so with all those added pressures, that's what I mean, is they're surrounded. Independent physician is surrounded to assimilate, to become employed in some make or model, whether it be through a payer, a hedge fund, private equity, or a health system. Because, you know, in their mind, there's less administrative burden for them with you know, dealing with the fax machine being broken or whatever it is. I feel like they feel like they just want to practice medicine and not have to do all of these other things and be responsible for all these other things. But as an independent provider, you can't, unfortunately, just practice medicine. You also have to be a business owner. And not all physicians go to business school. And so they rely on professionals to help them navigate these different challenging things that are ever changing.
Well, and it's not like getting a Subway franchise. A medical practice is a complex beast to manage, and there are people, colleges and universities that grant degrees in healthcare management, and guys like you, business people who know all of those things, like you can't file a claim with Medicare unless it's electronic, you know?
Yeah. That, you know, which diagnosis code do you have to have for which procedure, and how much of that will be covered, and which things can you do at the same time, which things do you have to do on different days. There's a whole host of hoops that have to be jumped through that have nothing to do with taking care of a patient, but that's where we are with healthcare right now.
So a doctor that I know, he said, when I first started my private practice, my wife ran my practice, and now I need an MBA to run the same practice. We also know that healthcare in the United States is more expensive than anywhere else in the entire world, and that we don't necessarily have better outcomes. In fact, on many fronts, we have far worse outcomes. But the greatest line item of expense, or the greatest group of expenses that make healthcare so expensive, is the administrative burden, the regulatory burden of that. Do you all see that?
I see that, but I also see the waste. There's a lot of waste in healthcare in our country. I'm going to give you a specific example. So what's called the in-office physician ancillary fee schedule, which is fancy talk for how much are we going to pay you, is provided by insurance companies to physicians. And that means for any ancillary services, you use the dermatology, vitamins as an example. For us, if we wanted to get an MRI machine at our orthopedic practice, because most of our patients have broken bones, they need to get an MRI to help our surgeons say, yes, I need to operate on that, or no, physical therapy will be fine for you in 6 weeks, and come back and see me and we'll see how you're doing. So that MRI right now, if you go to a major health system, can be anywhere from $1,500 to $2,500 reimbursable to the facility for the larger healthcare systems. For us, how much do you think we get?
No clue.
$300. Costs the same to run an MRI. So there's maintenance, there's, you know, WD-40 won't do it for an MRI. So you have to have professionals treat this equipment the right way. You have a technician, you have to have radiologists read the study. There's real costs running it. Yet for the same quality image that you could get with a major system, we would get $300 versus $2,500. Well, all of a sudden, the economics don't make sense for us to have an MRI. Even though that might be more convenient for you as a patient to go right next door to get your MRI with the group that's treating you versus down the road, and it costs your insurance company more money, but it also costs you more money if you're a cash pay patient.
Right.
So that's one example of where I don't know why insurance companies won't give us $600, maybe $700. We still don't want the facility reimbursed fee schedule, but that would make it economically viable just to cover our cost and then maybe make a small profit that helps us stay independent.
Yeah.
So you see the symbiotic nature of that.
Yep, absolutely. Well, we could have like 150 episodes just talking about how wrong health insurance companies get things
Yes.
because they pay for things that they shouldn't, they question things that they shouldn't, they require things that are unnecessary. Well, yes, we'll approve this surgery, but only if you do a series of 3, epidural steroid injections first, even though the surgeon might say, I can tell you right now, those aren't going to do any good. I'm going to put the patient through them because I've got to do that in order to get the patient the surgery that they need. And it's just, it's madness.
Yeah.
Well, and we're seeing some situations where that works, and there are some situations where that doesn't. And that's one of the things is I know they've got a difficult position too, in that, there are patients that are getting surgery that physical therapy would actually help. But there's some patients that the doctor will look at it and go, you know what, you can maneuver that all you want. It's not going to fix anything.
Yeah, right. Well, and the poor patient doesn't know who to believe because, well, most people know, does my health insurance company have what's in my best interest in mind, or they have their profits in mind? But there's also has developed distrust of the patients. Oh, well, is my doctor ordering an MRI for me just because the doctor's going to make money off their MRI scanner that they own? Or maybe the doctor has an ownership interest in the surgery center. Maybe surgery's getting recommended because of that. And there are instances of that, but it's, it's like in every profession, a few bad apples spoil it for everyone, but the patient can't differentiate.
It's I go back to what we might have said in our first episode is that's part of the noise of healthcare. There's so much information. What do I listen to? How do I interpret what's real and what's applicable to me as a patient?
And how can I really tell, other than with the limited data that's available and my spidey senses, how can I really tell a good doctor from a bad doctor?
Yeah, there's certain things you can do, and there's certain things you should do as a patient. But at some point, it comes down to having to make a decision.
Yeah. Well, I don't know if there's been any studies on this, but I have to believe that doctors who are exhausted, overworked, cramped for the limited amount of time they can spend within any individual patient, burned out, exhausted, as I said, I just have to believe that has an impact on patient safety. So it's an important issue that we've got to get addressed for all of our sake. And I hope it's a conversation we'll continue having going forward. It's not, we can have a 30-minute conversation of it and, problem solved. It's the beginning of what I hope are many more conversations.
Us too. I think it's good to talk about these issues, and our whole position is transparency makes us all better. Nothing will be perfect, but we could do better.
Yeah.
And I feel like that's what we get behind is, what, of course we're pursuing perfection. We know it's not attainable, but we really feel like better is attainable.
Yep. It's what I like to say, reasonable people having reasonable conversations. Some people would say, oh, she's the enemy, or oh, he's the enemy. And it's not that way at all. I think most all of us want better.
I think we want the same thing.
Yeah. Well, imagine that. Well, thanks again, Barry and Chad, for joining us. And I'm going to be hounding you to come back.
We would love to.
Would love it. Thank you, Kate.
All right. Thank you.
Thank you.
Thank you for joining us for another episode of Advocate. with Chad Erickson and Barry Howell. And I mean what I say. We could just go through thousands of topics that are relevant to patient safety and see if there's more things we can agree upon about what's broken and how we can possibly fix it. So thanks again for joining.